dear committee, dear friends, dear colleagues. It is really an honor and a pleasure for me to introduce one of my nicest colleagues from my department and also PhD student, Dr. Boglárka Pethő. Bogi was born at a given year in the very nice small town of Celdömölk in Western Hungary, if you're not aware where it is. And so she was admitted to Semmelweis University, and already during her university years, she did a lot of activities, scientific work in the so-called TDK, so the scientific circle of the medical students. Besides that, she worked as a teaching assistant at the Department of Physiology. And in the year 2013, she passed her final exam, where after her performance, I immediately invited her to join the institute, and I have to tell you that first of all she said no, but then she asked for some time to think about it, and fortunately she decided to join us, and so she works at our department from 2013. And she has passed her board examination in obstetrics and gynecology in 2018. And after that, she was one of the first colleagues to join this CTM team with her PhD studies that she will introduce in a short time. And you will see that she was one of the most successful ones of our group, not surprisingly. And she has published her articles in top journals that we are really very, very proud. So, ladies and gentlemen, the one and only, Bogi Pethő.
Dear committee, dear audience, welcome everyone. I'm Boglárka Pethő, and I'd like to present my PhD project investigating the role of maternal age in the occurrence of non-chromosomal congenital anomalies. I'm working as a specialist at the Obstetrics and Gynecology Department of the Semmelweis University since my graduation. I'm deeply grateful to my supervisor, Professor Nándor Ács, and to my scientific methodology supervisor, to Szilárd Váncsa, and to everyone who contributed to the work and the publications. It was an amazing team effort. My vision is a Hungary where pregnant women receive state-of-the-art pregnant care, which is the key to guarantee the best chance for new generation. And in this way, my mission is to improve the screening methods for non-chromosomal birth defects. As part of my thesis, I completed 2 projects to reach my scientific goals. I studied the effect of maternal age in the occurrence of non-chromosomal birth defects on a global level with a meta-analysis, and on a national level with a population-based study. In this chart, you can see the changes in maternal age over the past 30 years in the Hungarian population. The proportion of the advanced maternal age over 35 tripled during this period. And today, this is almost 20%. This percentage is even higher across Europe and in the USA. Delayed childbearing is the key demographic trend in modern societies due to high education levels, career goals, and changing norms. While the related medical knowledge is getting more and more precise and adaptive, advanced maternal age still has a real significant effect on fertility and the pregnancy complications. We have a little influence on these trends, so I think our task is to answer to them with appropriate sensitivity and effectiveness. Non-chromosomal birth defects are frequent, with a 3 to 5% worldwide prevalence, and they are the leading causes of infant mortality and morbidity. There is a well-known correlation between maternal age and chromosomal abnormalities. But we have less exact information about maternal age as a risk factor for non-chromosomal diseases. As visible on this graph, there is a sharp increase in frequency of chromosomal abnormalities with maternal age, which may explain why clear recommendations for them exist. And this is a lack in recommendations for non-chromosomal diseases. So our aim is to identify risk groups based on maternal age for the non-chromosomal diseases. Please let me start with the global level project. Why is it relevant to study this question with a meta-analysis? There are numerous studies in literature which are studying this topic and this question, but the results are really inconsistent and even conflicting. You can see in this slide 3 types for typical trends, typical results. A lot of studies found the risk increasing effect of the advanced maternal age, which typically means the over 35 and in some cases over 40 year category. While in contrast, others found the risk increasing effect of the very young maternal age category. And again, others found the risk increasing effect both of these categories. What was our specific clinical question? Our clinical question was, which maternal age categories pose the highest risk for different birth defects? Our study population was pregnant women, regardless the pregnancy outcomes, including live births, stillbirths, miscarriages, and we assessed maternal age as an exposure and compared different age groups. Our primary outcome was non-chromosomal congenital anomalies together, while our secondary outcome was birth defects individually or grouped together by ICD-10 category. According to our hypothesis, very young and advanced maternal age increases the risk of different birth defects. I'd like to shortly introduce our methodology. We carried out a systematic search in 3 comprehensive databases, and in the end of the selection process, we had more than 70 articles for the mathematical synthesis. During the preliminary search, we identified 6 maternal age groups according to the literature, and we searched for relevant data in the eligible articles. In the next slide, I'd like to present our clinically most relevant results. Our systematic search resulted in an overarching set of studies representing all continents during the nearly 8-decade-long study period. This is our primary outcome when we analyzed all non-chromosomal congenital anomalies together, and I wanted to show it just as a quick impression. We analyzed all of the age categories, and you can see here our clinically most important finding in this question. We found a relevant effect at the advanced maternal age categories over 35 and over 40. You can see in the forest plot in the left side the individual articles. We analyzed 13 articles in this question. The reference group was in every setting between 20 and 30. And you can see here the comparator group and in the reference group also the sample sizes. The effect measurement was in relative risk. You can see that in the right side for each articles. And with highlighted a red mark, you can see the pooled relative risk below them. And in the middle of the forest plot, you can see the visualization of the results. And we found the risk increasing effect at both advanced maternal age category, over 35 and over 40. And these results are both statistically and clinically significant results. As a subset analysis, we analyzed all non-chromosomal congenital anomalies without the co-occurrence of chromosomal abnormalities. We know that the co-occurrence of chromosomal abnormalities is a relevant risk factor for the birth defect, so it's a relevant confounder also. And we found again the risk increasing effect of the advanced maternal age category, but just over 40. The early diagnosis of congenital heart defects is crucial. Due to their severity and their frequency, they are the most common group in birth defects, among birth defects. And there is an additional screening method for them, fetal echocardiography. And today in guidelines, there is no maternal age-related indication for them. We found a risk increasing effect both of the advanced maternal age categories, both over 35 and over 40. And we found a preventive effect at the very young maternal age category with decreasing risk. At the group of cleft lip and palate, we found again a risk increasing effect of the advanced maternal age category. Gastroschisis is a severe abdominal wall defect, which is also rare. It's clinically important to analyze because its incidence increased over the last some decades. And after birth, it needs immediately surgical interventions for survivor. We found that very young maternal age triples the risk for gastroschisis. This is just a quick overview and reminder. We found the risk increasing effect of the advanced maternal age, mostly over 40 in many cases and many anomaly groups, while we found the risk increasing effect of very young maternal age in some individual cases. And I'd like to shortly highlight the main strengths and limitations of this study. First of all, it was the first meta-analysis which exclusively assessed non-chromosomal birth defects based on maternal age. The huge case number and article number, which are all over the world, make our results generalizable. While the main limitations were the inconsistent categorization of the outcomes, the high heterogeneity, and the ignored confounders, because it was an univariate model. Please let me continue with my second project, with the national level project, following the same structure as previous. We had a high reason to study this question in the Hungarian population because the prevalence is the same as it was the worldwide project for birth defects. And in Hungary, about 30% of live births fall into the high-risk maternal age zone. And in addition, in Hungary, there is a mandatory notification of congenital anomalies. As you can see in this table, there is exceptional notification coverage among European countries. Our clinical question was the same as it was in the worldwide project, but for the Hungarian population, which maternal age categories show the highest risk of different birth defects. We followed the same structure and created the same PECO framework, and our hypothesis was also the same: very young and advanced maternal ages increases the risk of different birth defects. We collected our data from the Hungarian Case Control Surveillance of Congenital Abnormalities database, which is a really unique database due to its size, its comprehensiveness, and a wide range of information. And we compared our data with data from the Central Statistical Office, and with this we analyzed really 3 million pregnancies during the study period. In this first result slide, I'd like to shortly explain our statistical method. You can see here our primary outcome, which was again all non-chromosomal congenital anomalies together. In contrast, in the literature regular used method and concept, we wanted to avoid to use arbitrary or also non-artificial maternal age categories. Instead of them, in the first step, we identified the lowest risk maternal age period, where the relative frequency was the lowest. We identified it for each anomalies, for each anomaly groups, and for the overall. For overall, you can read it in this slide. It was between 23 and 32. And you can see in the graph with the gray field. In the second step, we used this best 10-year period as an age reference, and we compared each maternal ages to this to identify the relative risk for each maternal ages. And in the third step, we applied nonlinear, non-parametric regression to identify any trends. You can see the relative risk with the circles in the graph, and among the trend line, you also can see the confidence interval, which was quite narrow in this case. In the end, it's a bit wider because the lower case number. And with this analysis, we found that there is a risk-increasing effect of both very young and advanced maternal age in the Hungarian population. Analyzing circulatory system anomalies, we found the risk-increasing effect again at the very young and advanced maternal age category, but the risk-increasing effect was higher at the advanced maternal age category. At cleft lip and palate, the trend was similar as it was at the circulatory system anomalies, with a higher risk-increasing effect of the advanced maternal age category. Analyzing nervous system anomalies, or also non-neural tube defects, we found an association with the very young maternal age, which is a clinically important finding due to the existing additional screening method, again, fetal neurosonography. At urinary system anomalies, we found the risk-increasing effect at the advanced maternal age. While analyzing respiratory system anomalies, due to the low case number, we couldn't neither confirm or deny any association with maternal age. The huge case number, the unique database and data collection methods, and as I mentioned, the novel statistical approach without using arbitrary age groups, it may reflect the reality more. While the main limitations were the changing screening methods and detection rates during the long study period, again, the ignored confounders because it was, again, a univariate model, and the fact that the data collection ended in 2009. I'd like to summarize our clinically most relevant results and highlight the main conclusions also. In this figure, you can see our clinically most important findings, and I like to emphasize where the trends are consistent and the effect sizes show correspondence. We know that meta-analysis is a higher evidence level, but the evidence can be the strongest when our results or studies point in the same direction. We found a same trend and a similar effect size for the overall result, for circulatory system anomalies, and for the cleft lip and palate over 40. After analyzing this same topic, this same question on a national level and on a global level, we can confirm that very young and advanced maternal age increases the risk, the different birth defects. We should highlight and pay attention to very young mothers. I think this is an underestimated group when we discuss birth defects. And we have to highlight here the risk increasing effect for abdominal wall defects and neural tube defects in the Hungarian population. And advanced maternal age seems to be a real relevant risk-increasing factor for the non-chromosomal birth defects, and we found this association in many cases in many anomaly groups. I think it's also a clinically really important finding due to the global trends of delayed childbearing. We hope that with our new findings, we can specify screening methods. Of course, it can be a long-term goal, as I mentioned, for fetal echocardiography and fetal neurosonography. And we highly recommend to unravel the biological background of our findings and for future projects to consider confounders during the planning and data collection period. And with this, it creates an opportunity for multivariate model, which can be the next step and the next level. In this slide, you can see my publications and scientometrics. I'm really proud of our students who worked together with us and presented our research with success in the Student Scientific Conference. More than the clinical and the research implication, it's the same important to reach everyday people, not just professionals. We are very happy it could happen both nationally and internationally. The last some years were real significant and special in my life. During my PhD journey, when my son was born, I saw it truly from the other side. And it made me realize even more how meaningful our work is as researchers and doctors. At the end of my presentation, I'd like to thank everybody who contributed to this work and made it possible. My supervisor, Professor Nándorács, and his continuous support. To all of my colleagues, students, and especially to Pethő, the head of the Translational Medicine Center. The center gave us opportunity to know the scientific world as deep as possible, and we received not just a professional methodology team behind us, but I think the real ability to carry out our work on a highest possible quality. Thanks for that. And thank you. And let me close my presentation with the quote of Nobel Prize laureate Albert Szent-Györgyi. Research is to see what everybody else has seen and to think what nobody else has told. Thank you for your attention, and all questions are welcome.
Thank you very much, Bogi, for this very clear and very logically structured presentation. And first, I'd like to ask you, Professor, to ask your questions.
First, I would like to thank Professor Peter Hegyi for the invitation to participate as an opponent in this public defense of the doctoral PhD thesis of Ms. Boglárka Pethő. It is a great honor and a great pleasure to be here with you. And on this occasion, I would like to extend greetings from our University of Medicine and Pharmacy of Iași, from our rector, Professor Viorel Scripcariu, and from our doctoral council. Regarding the doctoral thesis, this doctoral thesis comprised a retrospective study that evaluated the impact of maternal age on the occurrence of non-chromosomal congenital anomalies using Hungarian National Registry that included more than 3,000 cases and that act between 1980 and 2009, almost 30 years period of time. Congratulations for this National Registry of Congenital Anomalies that we don't have in Romania, unfortunately. So first question would be, how did you collect the data for this congenital anomaly database? Did public hospitals or private clinic have to report annually the diagnosed anomalies, congenital anomalies after birth, after termination of pregnancies, or after miscarriage? And this was an obligation to report mandated by law, and why did it stop in 2009?
Thank you for the question. The concept was to represent all of the Hungarian population, and the data collection method was, I think, also quite unique, and this gave the biggest opportunities which are in this database. The database in the database, professionals collected the data, so this is the one of the highest impact, I think. Professionals did it within 3 months when realized the birth defect, and it was, yes, after miscarriage, after termination, and after live birth, stillbirth, and it was the first step. But in the second step, the mothers received the questionnaire, and they filled that. And there was a supplementary data collection also, where local nurses helped to analyze the other medical documentation. And yes, unfortunately, the data collection ended in 2009 due to funding problems.
Okay. I want also to stress some strong points of this thesis. First of all, this thesis is reporting congenital anomalies from Hungary over a period of 30 years, and this database allowed for the evaluation of trends, specific anomalies that are increasing in frequency or decreasing in frequency. Another strong point of the thesis is that it was that the PhD student conducted the meta-analysis that includes 71 international studies to verify the statements issued from this national registry database. Some statements were confirmed and some statements were not. And the third strong point is that Boglárka tried to find out explanations for these age-related congenital non-chromosomal abnormalities, also for young mothers, but also for older. What I want to say, chromosomal abnormalities are those that are detected by karyotype, and therefore they can be seen under microscope. But there is a large, wide range of non-chromosomal genetic abnormalities that can be correlated with advanced maternal or paternal age. Like Marfan syndrome, achondroplasia, that are related to enhanced paternal age. So the last two questions are, was the paternal age reported in the revised article of the literature? And the second one, if in more recent articles about congenital anomalies, the author reported genetic tests that are beyond karyotype, so Hacher array, exome sequencing, whole genome sequencing, of course, maybe in the last articles published, not the articles published 10 years ago. And if the answer is yes, maybe this could be your subject for next meta-analysis.
Thank you for also the suggestion and the questions. My answer would be for the first question. Yes, paternal age can be a relevant risk factor for non-chromosomal birth defects. The literature is not real consistent in this, and the effect can be higher for the chromosomal abnormalities. But many studies found the risk increasing effect over 40 at fathers for congenital heart defects. It was, with congenital heart defects was the association the clearest and the strongest. While others found over 45 this association. And the relative risk was about 1.3 with this. It was the question of the reference population, of course. In our database, there is data about paternal age, and in our group, there is a research with this today.
Thank you, and I want to congratulate you for the national Hungarian database on congenital anomalies, and for the two articles that you published in very high impact factor peer-reviewed journals. Congratulations.
Thank you very much.
Good luck for your future.
Thank you very much.
Thank you, and this is the time for you as well to introduce Professor Nagy from Szeged, and then you can just ask your questions.
Thank you very much. Dr. Boglárka Pethő, I congratulate on your amazing thesis. It's just absolutely wonderful and very impressive that you have published two first author scientific papers in D1 journals. And it's a beautiful thesis, well edited. I just, as an additional information for the audience, I would like to highlight that more than 200 references have been added to the thesis. It's beautiful work. So the topic is really relevant, and I just already read in your thesis that the association between the chromosomal congenital anomalies have already been established with maternal age, but in your thesis at the beginning you have written that the association between the non-chromosomal congenital abnormalities and maternal age is still debated. So could you please mention some of the literature background about this debate, who published and what were the results? And
yes, we know that when the mother is over 35, then the risk increasing effect is real clear and real high for the chromosomal abnormalities. I think because of this, there is a real clear screening method for them, and there is no this real clear association with the non-chromosomal defects. At the chromosomal abnormalities, we can say also that there is an influential factor for the non-chromosomal diseases, about 40% higher increase the risk for the non-chromosomal diseases when there is a co-occurrence with the chromosomal abnormalities.
In the method section, you just mentioned a few guidelines which help you in the design of the population-based study and the meta-analysis. Could you please tell us about a few things about these guidelines?
Thank you very much. I think this is a real important part, both of these articles, that we rigorously followed these methodological recommendations. It was the Cochrane Handbook and PRISMA guideline for the meta-analysis, and it was the STROBE guideline for the population-based study.
And I have noticed that you registered on Prospero the meta-analysis.
Yes.
And I just wonder whether the registered protocol is the same as the published one, or the one appears in your thesis, or have any changes occurred due to any scientific reason?
Yes, when we worked on the meta-analysis, we had to change some little delicate things, and we also published it in the related article. The cause was that we realized during the preliminary search and during the search that we have somewhere not enough data, or we realized some really important part of the data quality, and we had to make some real small changing.
I have noticed that you didn't group the patients according to their age, but used a specific method to calculate the most affected maternal ages. Could you please tell us a few things about this?
Yes, thank you. Yes, it was technically it was a hard part of the meta-analysis also, because in literature there are so many type of reference age categories. It was also not clear, and there are so many settings with analyze this question. And one of the main targets was both of these studies to identify this reference age category. And we did it in the population-based study, and then we used that in the meta-analysis. Would you hear the method of this? Okay. So our concept was, without using arbitrary age categories, to identify the lowest risk best tenure for each anomaly groups, and for the overall. After we identified this best tenure, which was with the lowest relative frequency of birth defects, then we used this age category as a reference age category, and we compared each maternal ages to this to identify the relative risk. And in the third step, we applied nonlinear, non-parametric regression to identify any trends.
I have also noticed that you have included 72 population-based studies into the meta-analysis. Could you please tell us from which countries have these studies been published? Were there any countries which were overrepresented, or is it a worldwide?
Yes, thank you. It's a real important question. Yes, from worldwide, and which are overrepresented, I think, from the USA and from Europe. But I think this is also a strong part of this study, that these are real from all over the world, and they represent all continents.
Regarding the results, I just would like to kindly ask whether did you notice any protective effect in your data? I mean, we are talking about a lot about maternal age with increased risk, but maybe you have find something opposite.
Yes, in one case we found a circulatory system anomalies in the meta-analysis. We found a slightly protective factor for these congenital heart defects at the over 20-year category. Under 20, sorry. Yes.
Perfect, thank you very much. And I just wonder whether do you have any suggestion how we should modify the prenatal screening protocols using your data? How should we implement it into the everyday practice?
Thank you for your question. Yes, I think it would be the most important implication for all projects, and also for us also. I mentioned there is no maternal age related indication for fetal echocardiography and fetal neurosonography, so I think it can be a long-term goal. Of course, this is a descriptive epidemiological study, but I think it can be a real hard initiation for other studies to analyze this question more detailed and in other ways.
I also wonder whether, what is your opinion, experiencing this tendency of the childbearing age is just going higher and higher, how would the frequency of the non-chromosomal congenital anomalies in a future Hungarian population will see?
Thank you, it's a real interesting question. I found in literature, I think it's a real interesting thing, but it's not changed over the samples decade, so it's this 3 to 5%, but the different birth defects and their prevalence changed. For example, gastroschisis incidence increased, and this is typical for the very young population. But I think when this tendency will standard in the next some decades, then I think it can be higher and higher.
Thank you very much. And I also prepared a few questions which has already asked by my colleague. So thank you very much.
Thank you very much.
Although it seems to be already finished according to the number of questions, but I still ask the other committee members whether do you have any questions or comments?
Thank you very much. Congratulations on your thesis. It was really beautiful work. I just have one question that you mentioned that in terms of gastroschisis, a low maternal age is a threefold risk for for gastroschisis.
Yes.
And also in your thesis, that was that the advanced maternal age has a protective factor, on the contrary to other non-chromosomal defects. What do you think the cause could be that advanced maternal age protects against gastroschisis?
Thank you. Yes, it's an interesting question. According to literature, there is a quite, if I can say, clear hypothesis to why the young maternal age. And the answer is that at very young mothers, the hormonal imbalances elevates the estrogen levels, and with these estrogen levels, the thrombosis occurs more. And if this thrombosis occurs in the umbilical vein, then it can weaken the abdominal wall. So this is one of the theories, but I think, and again according to the literature, which say very young maternal age not looks like as an independent risk factor. So I think the higher effect can be in the lifestyle factors, the drug abuse. Yes.
And the advanced maternal mothers don't use substances, according to that?
Probably sometimes, where they are so prepared. So I think.
But do you think that could be the only reason, or could it have an effect on additional either genetical effects that terminate that pregnancy?
Yes, it can be, but this protective factor, I think, rather just a contradiction, I think. So they say the numbers, but I think it's a question of the reference age category. So I would rather highlight the risk increasing effect for the very young mothers than this effective, this protective factor.
Okay, thank you very much.
Thank you.
From the audience, do you have any comments?
Hi. So I don't know if I'm qualified to say that, but good work.
Thank you.
As a first-year student. My topic is somewhat similar. It's also on the effect of microplastics on fertility, mainly male and then animal models for now. And just out of sheer interest, since you seem to be much more advanced in the topic, and I'm sure you stumbled over the literature in some ways, do you know of any endocrine factors which impact fertility extensionally, such as, for example, microplastics or anything similar?
Thank you for your question. Yes, endocrinologist factor can be relevant in this question. For example, when we say IVF is a risk-increasing effect and IVF is a relevant confounder, then we say not just about the procedures, but behind them the basic endocrinological problems. For example, PCOS can be related to this topic.
Thank you.
Thank you.
More questions? Other side, okay.
So thank you for the presentation. It was really nice. I have a few questions. So my first is regarding your meta-analysis, that you mentioned that your 70 or so articles included data from around 8 decades.
Yes.
And did you consider during the analysis to see whether the older articles and the newer articles have the same, show the same tendencies, or are they different? So let's say before 1990 and after 1990. Or
Yes. Basically, our concept was to do it without any chronological or geographical limitations, to give a whole picture. But during the process, yes, we analyzed this, and it was a surprise for me, but we couldn't realize any relevant difference between them, and we couldn't find any trend.
Okay. And my other question would be that you mentioned quite a lot of anomalies, that some of them had better outcomes when the mother was younger, some of them was worse when the mother was younger. Would you, in the future, would you be able to make a ranking of these anomalies and some kind of weight those together to get the real optimal maternal age? Because as far as I understood, you just looked at the one or
to determine this 10-year, but maybe if you weight these different anomalies together, like one is more severe than the other ones, and then the safe range for that more severe one should be weighted in more for the calculation of the maternal age window. Would you be able to do it? So.
Thank you for your suggestion. If I understand you well, you suggest that we should analyze each anomaly and then rank them on the question of seriousity.
More or less, yes.
Yes, we didn't do that, but we analyzed this and identified this best 10 year for each anomalies. So we could do it, yes, with this. But I think probably the clinically most relevant result can be when we analyze the overall. So I think at this frequency, which is at this type of birth defects, it can say the most.
Okay, thank you.
I would like to have just one comment or question. And so far, I remember at one of the last slides, you demonstrated that there were actually no statistical difference between the relative risk in the Hungarian population and the nationwide population. And I think it's a very important message. You mentioned that this is one of the limitations of your studies, that the Hungarian population go back to 30 years. However, you proved, on the other hand, that it was not a limitation. No matter that the screening system evolved, the relative risk is almost the same. So it's, on the one hand, a limitation, yes, but it's a clear evidence that nothing has changed in the last 20 years. So it can be also explained by that. Okay, any other questions?
Thank you.
Then thank you very much for that.
Thank you.
Congratulations on the first place. Just we take a short break, go out, make an evaluation. Please take the QR code, because I will be notified again that I forgot that, and then we'll come back. So I would kindly ask everybody to stand up for the decision making, and I would kindly ask you to please come on the stage. There is only proud for you to be there. I'm very happy to announce the result of the decision. It was a very, very straightforward decision, no doubt. There were 100% of all the committee members. Your presentation, or your results, the way of you were debating was outstanding. So 100% for you, all 5. Congratulations to you.
Thank you so much. Thank you.
Thank you. Just have a seat. I would like to make a short comment for you as well.
Thank you.
So as Professor Hegyi told, and you emphasized it also in your presentation, that it's very important to put to put scientific data into everyday knowledge, and I think it's a very nice and a very bright example of that, because first, as basic scientist, I have a quite strong basic science background. And first, you have to convince the clinicians that what you are doing there has clinical value and clinical evidence and clinical use. And this is a super nice example. And after that you have convinced the clinicians, and they applied your results, and they apply your discoveries, you have also convinced the society and the population that what we are doing as clinicians, doctors, researchers, whatsoever, has a population value, and it's very important. And your example from the very beginning until the end, and also these social media and news presentations are a super nice example for that. So please be very proud of yourself, your team, your mentors, and also a bit grateful for them. And I think this is the most important responsibility of the Translational Medicine program, to to make this continuous progression from the very beginning to the everyday usage. So congratulations to you.
Thank you so much. Thank you.